We have a 57-year-old patient who has a history of cutaneous melanoma involving his cheek that was resected and then spread to the parotid gland, which was also resected and had 4 involved lymph nodes. Unfortunately, this patient, after all of this surgery, at a restaging PET scan about 6 months later, was found to have diffuse metastatic disease involving the liver, lungs, and bone. And importantly, a biopsy of one of these metastatic sites reveals the presence of a BRAF V600E mutant melanoma. And this is a patient now with metastatic disease, 57 years old, BRAF V600E mutant melanoma, with pain in the bony lesions from a number of the melanoma metastases. The question really is upon ourselves is, what is the best initial treatment for this particular patient? We have immunotherapy agents like ipilimumab, PD-1 agents like pembrolizumab and nivolumab. We have the combination of ipilimumab and nivolumab, and we have BRAF and MEK targeted therapy, which is given in combination, either vemurafenib and cobimetinib or dabrafenib and trametinib. So how do we choose among all of these different options to treat this particular patient with symptomatic BRAF V600E mutant metastatic melanoma? There's a lot of different options. All of these one could make an argument for choosing for this particular patient. For me, I would think about either a PD-1 based immunotherapy approach and or the combination of BRAF and MEK inhibitors. I think among all of these different options, the first thing I would say is that since PD-1 drugs have demonstrated superiority over ipilimumab as a single agent, I would put ipilimumab as a single agent to the bottom of the list. Secondly, the decision between PD-1 based immunotherapy or BRAF plus MEK BRAF plus MEK targeted therapy, I think is a real challenge. We see very similar efficacy long-term with PD-1 based immune therapies as we do with BRAF and MEK inhibitors. However, that initial immediate response rate and initial immediate palliation of symptoms is greatest with targeted therapy with BRAF and MEK inhibitors, such as vemurafenib and cobimetinib and dabrafenib and trametinib. So for this patient that's symptomatic with bony metastases with the BRAF mutation, I would probably choose BRAF and MEK inhibitors as initial treatment to result in immediate palliation.